Welcome back, my friends, to part 2 of our notes on the cardiovascular system and blood. In this one, we're going to take a look at blood type. We're going to take a look at blood clotting and at some more blood disorders. So let's jump right in. Hemostasis, folks, hemo for blood, stasis for consistent or keeping it the same, is simply a series of reactions designed to stop bleeding. During hemostasis, there are 3 phases that occur in pretty rapid succession if everything's working properly. The first thing that's going to happen when you get a cut is you're going to get vascular spasms. The vasoconstriction is going to happen in response to the injury. Now, there's smooth muscles around our vessels, right? And if there is a cut here, the vessels upstream from that cut are going to constrict to reduce the blood flow to that area. Generally, particularly if they're larger ones, they're not going to be able to constrict all the way and block it off. And blood still needs to get through to other parts of the body, but it does slow the bleeding. The next step would be platelet plug formation. This is like us putting pressure on the wound, right? It's the quick, immediate response, which is going to slow the bleeding and give time for the more permanent method of sealing it off, which is coagulating or coagulation, blood clotting. So let's go to the second step because vasoconstriction is already pretty simple. Platelet plug formation. So platelets normally don't stick to each other or to the endothelial lining of the blood vessels. It's smooth. Remember, we learned about this way back in histology. That lining is a single layer of simple squamous cells, very smooth, very flat, difficult for things to stick to it, which is what you want in your cardiovascular system. You don't want clots forming all the time, blocking flow to things. You want a nice, smooth, efficient flow of blood through the vessels. So platelets normally don't stick. Okay? However, when you get damage to the blood vessel, when you get through that layer, just below that, you're going to have collagen as the next layer in the blood vessels. It's normally not touching the blood. That collagen is kind of sticky to platelets. Okay, platelets are going to stick to it kind of like Velcro or a magnet. All right, they're just going to get stuck there. All right, and when they get stuck there, they're going to release serotonin, okay, and ADP, which is going to attract more platelets. Okay, and then more platelets are going to attach, releasing more serotonin and ADP, which is going to bring in more platelets, which is going to release more of those signaling molecules, to bring more platelets. Got a positive feedback loop starting, right? Rather than trying to bring things back to normal, it ramps it up because it's trying to speed this up and get it done fast. So a little bit of clotting or a little bit of platelet plug formations is going to get more platelet plugs, which is going to get more platelet plug, and we clot it up. Okay. Now the platelet plug is limited to the immediate area of the injury by a hormone called PGI2. Keeps it from hopefully forming clots elsewhere. You just form it where you need it. Is it always perfect? No, but it works pretty well most of the time. Okay. Coagulation can get complicated. What we're going to do at this level and with the time we have this year for it, it's a set of reactions in which blood is transformed from a liquid into a gel. We can see some of these fibrin molecules forming this net, which is going to trap red blood cells in there and is forming this coagulated clot. I don't know if you've ever had this, but if you ever had a bloody nose and then you go and you're putting the pressure on and you stop it and you got the tissue there and you pull it out and you get this kind of almost looks like Black Forest jello blob that comes out, that's coagulated blood. Okay, it's no longer liquid, it is now more of a gel to kind of fill in that area and keep you from losing more blood. It's kind of gross, I know.
In a first step towards clot formation, platelets are recruited to the site of vessel injury by now exposed molecules of the vessel wall, such as collagen and von Willebrand factor. This factor mediates the linking of platelets to collagen via a specific receptor in the platelet membrane. The resulting change of shape of the platelet from its resting state into the dendritic form indicates activation. The activated platelet in turn releases prothrombotic molecules such as adenosine diphosphate, ADP. By binding to its receptors, ADP induces aggregation. and recruits further platelets to the site. Thromboxane is another important mediator of platelet activation and aggregation. Under its influence, the platelets cross-link with each other. These interlocking mechanisms cause platelet activation to snowball. The clot grows rapidly. Activated platelets also trigger the coagulation cascade and thus the formation of thrombin. Thrombin, in turn, stimulates platelet activation even further, a continuous feedback loop. Additionally, thrombin induces the formation of fibrin for the mesh stabilizing the clot. The self-reinforcing process of platelet activation, crucial in the formation of blood clots, is an obvious therapeutic target in conditions caused by inappropriately triggered blood coagulation.
All right, so clotting is good if you're losing blood, but you don't want clotting when you don't need it, okay? Because then it restricts blood flow to areas of the body that need the blood. So how do we prevent that? Well, unnecessary clotting is prevented by the structural and molecular characteristics of the endothelial cell linings themselves. Like we said, it's very smooth, okay? Heparin and PGI2 is secreted by those endothelial cells. Those are anticoagulants. Some people might actually get heparin injected at the hospital if they're worried about too much clotting. They'll give you an extra dose of it to reduce the chances of clotting. And then vitamin E and quinone is also a potent anticoagulant. Those are all things that help to keep it from clotting when it shouldn't. Okay. Some other disorders, thromboembolitic conditions. I've got up here, you can see, we've got a blood cell, we've got the endothelial lining, and then we've got that collagen matrix underneath, right? Which is what usually we have to expose to get a clot to form. And then we've got this tissue factor right here, and this thrombus is sticking there where it doesn't need to stick. And it's also showing the smooth muscles around that we talked about with vasoconstriction. But it's sticking there, and we're forming a clot in a set location in a vessel. That's what a thrombus is, a clot that develops and persists in an unbroken blood vessel. If it's existing in a broken blood vessel, that's good, but if it's where you don't need it, that's bad. It can block circulation, resulting in tissue death downstream. A coronary thrombosis, a thrombus in a blood vessel of the heart. This is a fairly common cause of heart attacks, right? A thrombus in the major coronary vessels that bring blood to the heart itself can cause that heart muscle to be lacking oxygen and glucose, or hard to get rid of waste products, and that part of the muscle that's being supplied by that dies. Heart attack, okay? Or one version of a heart attack. Okay? An embolus, okay, is a thrombus that's freely floating in the bloodstream. So it's a clot that's moving around. So it can form all sorts of different places, break loose, and then float around. That in itself isn't bad. What's bad is when it gets stuck somewhere. So here we can see down here we got an embolus that gets stuck in a thrombus. So if you have a thrombus somewhere that's not completely blocking off blood flow, maybe you're not noticing an issue, but the second you got an embolus break free, gets stuck in there, now all of a sudden you got a major issue very quickly. It's not a slow developing thing. It's going to happen fast. Pulmonary embolism are ones that can impair the ability of the body to obtain oxygen. So pulmonary deals with the lungs. Cerebral emboli can cause strokes. Those are ones in the brain. That's one type of stroke where you can't get blood to a certain part of the brain. Another type would be if you got a burst blood vessel in there, an aneurysm that bursts, and then obviously you get bleeding in the brain that way too. So there's a couple different ways you can get a stroke, or what we commonly call strokes. All right, so how do we prevent that? What do we use clinically? Aspirin. It's an antiprostaglandin, PGI, right? We talked about before, that inhibits thromboxane A2. All right, you'll see that a number of people get prescribed like a baby aspirin, a small dose of aspirin every day to help keep their blood, make it a little less likely it's going to clot. If you're on a lot of aspirin, it can actually be hard. So people who have that aspirin every day, they may not clot as well. They'll bleed a little bit more than they would have otherwise. And then there's some much stronger ones like heparin we talked about before, and some other ones that people use after surgery. when you have surgery, especially major surgery, internal to the body, there's a delicate balancing act, right? You want those wounds to close and seal up and clot so you don't have excess bleeding, but you don't want too much clotting because then you can form thrombi and embolisms that can get stuck in the legs and the lungs and the brain and the heart and cause further complications. So after surgeries, there's a balancing act trying to make sure your blood is clotting enough, but not too much. It's one of the things the doctors are watching. Some other bleeding disorders, thrombocytopenia. It's a condition where the number of circulating platelets is deficient, so you don't have enough platelets, which means it's going to be harder for your blood to get that quick platelet plug formation. Okay, people who have this will often show something called petechia, small purple blotches on the skin, and that can happen due to spontaneous widespread hemorrhage. So you get those little spots there where the blood vessels are broken, but they're not clotting as quickly as they would have otherwise. It's also a sign of somebody being asphyxiated. If you see petechia on the face, it's a sign that the pressure built up in the blood vessels of the face, causing lots of little bleeds. Because when somebody's getting choked or restricted here, the veins that are bringing blood back down are easier to close off than the arteries taking blood up, because those are under higher pressure. So blood will still get through, okay, but it can't get out. So we build up pressure up here because of that, and we got lots of these little bursts. So thrombocytopenia can be caused by suppression or destruction of bone marrow, which can be a side effect of a cancer or radiation to cure cancer. Platelet counts less than 50,000 per cubic milliliter, okay, is diagnostic for this condition. That seems like a lot, right? Well, you can get a lot of those things in a cubic milliliter of blood. And we treat it generally with whole blood transfusions. We just give people whole blood that'll have, red blood cells, white blood cells, and platelets. Hemophilia, and there's a bunch of different versions of hemophilia, are hereditary bleeding disorders caused by a lack of clotting factors. Now, we didn't get into all the different steps in the clotting process because it is quite complicated, and we just don't have the time, unfortunately, this year. But the different hemophilias are due to which clotting factor is not working properly in that big old cascade. This happens, and this happens, and this happens, and this happens. If it's here that it gets messed up, it's a different type of hemophilia than if it gets messed up with this part of it. Symptoms include prolonged bleeding and painful and disabled joints. So these folks have a hard time stopping bleeding, and you're always breaking minor blood vessels and capillaries in your joints due to impact, okay, on those joints, and they bleed in there. But normally we clot and we don't notice it. They don't, and so the blood gets into those joints, then it kind of gums up the works, gets sandy in there, and get grinding in those joints, because instead of having that nice synovial fluid in there, now you've got bits of other junk in there. And we treat that with blood transfusions, and in some cases we've developed the ability to isolate and or produce those missing factors, and we can inject them regularly with those to help them with that. Okay. Blood transfusions that you may have heard about. Whole blood transfusions are used when blood loss is substantial. You're just losing lots of blood, so you need everything that's in the blood, or in treating thrombocytopenia. Okay. Packed red cells, cells with the plasma removed, are used to treat anemia because you don't need all the other stuff. You just need the red blood cells because you don't have that oxygen carrying capacity, but you got plenty of plasma and stuff. So they'll just give you the red blood cells to build your oxygen carrying capacity back up. I don't have anything about plasma, I guess, but plasma would be the opposite. You got plenty of the cell. You just need volume because your blood pressure is dropping, and if they can't give you whole blood, they can give you plasma to build up your blood volume. Let's see. Oh, human blood groups. Red blood cell membranes have a glycoprotein antigens on their external surfaces. And I'll draw some pictures over here and put them up. They're kind of like, those antigens are like little ID flags. Okay, have you ever seen Duck Dodgers in the 21st and a half century? It's a Warner Brothers cartoon with Daffy Duck and the alien guy Marvin, right? And Daffy Duck comes out of his spaceship and he plants his flag in the planet and says, I claim this planet in the name of Earth, and that flag identifies it as belonging to Earth. And then Marvin gets out a little bit later and says, I claim this planet in the name of Mars, and plants his flag in the ground. And then they fight out over, who actually owns the planet. But those little flags in that planet always remind me of antigens. Okay, They're little ID markers on the surface of our cells that tell our body that that cell belongs in our body. All right. It's how our immune system knows not to attack that cell. That doesn't have the right flag. We're taking that thing down. Okay. It does it to the bacteria. You probably heard about this with COVID, right? That's what the vaccines are working to get your body to do, is to recognize the antigens on COVID and attack them. Okay, giving your body practice so it can attack those antigens. Well, our red blood cells have lots of these ID flags. Human blood groups are the ones you're probably most familiar with, like A positive, B negative, those kinds of bloods. We'll talk about them. We'll do a lab with them in class and try to figure out your blood types. But those are the most common, but there's a lot of other ones. But that's how our body recognizes if it belongs or doesn't belong in our body. If it doesn't, it's going to promote agglutination, which is clumping. So that you can clump up that foreign invader and get it out of your body. Okay? And presence or absence of these antigens is how we classify different blood groups. We have 30 varieties of naturally occurring RBC antigens. Okay? The antigens of ABO and RH blood groups, those cause very vigorous and fast-acting reactions if you get the wrong one. And that's why that's what they're looking for when you donate blood or receive blood. They're matching those. The other ones are important. The M, the N, the Duffy, the Kell, the Lewis. Those we'll use for legalities or if we're trying to do organ transplants. The more closely we can match all of those antigens or ID flags on an organ's tissues, the less likely your body's going to try to reject that organ and kill it. So even though that heart transplant is saving your life, your immune system doesn't know that. It just says, hey, that heart isn't our heart. That tissue isn't our tissue. Let's kill it. So you want to try to match as many of those as you possibly can. The more you match, the better chance that the patient won't reject the organ. Even with that, they still have to take immunosuppressant drugs, usually for the rest of their lives, so their immune system doesn't kill what's keeping them alive. And that's why folks with transplants and things are highly susceptible to COVID. And other diseases like that, and they got to be extra careful about it because their immune system is suppressed and it's not going to work like it usually does. Okay. So the ABO blood groups consist of two antigens, A and B, on the surface of red blood cells. Okay, and then two antibodies in the plasma. Anti meaning against, bodies, foreign bodies. Anti-A and anti-B. Anti-A will kill anything with an A flag. Okay, and anti-B will kill anything with a B flag. So if you have type A blood, are you going to have anti-A or anti-B antibodies? Yeah, anti-B. You wouldn't want anti-A if you got A blood because you'll kill your own blood. So if you got A blood, you're going to have anti-B antibodies. Okay, and then vice versa. If you got B blood, you'll have anti-A antibodies. An individual with ABO blood type may have various types of antigens and spontaneously form pre-antibodies. Sometimes, if you've never been exposed to the other blood type before, you're not going to have a lot of antibodies to it. Just like if you've never been exposed to COVID before, you're not going to have a lot of antibodies to it, which is what makes you sick. But if you've been exposed before, you probably got antibodies already built up because you've practiced this before and you kill it quickly. So if you get a blood transfusion and stuff like that, depending on what your exposure has been, you may respond quicker or slower. All right, quick wardrobe change here, guys. Different day. Just had a cut off by the bell on that last one. So taking a look here, what we've got here is a nice chart of the different blood groups, the frequency they appear in the U.S. population by different genetic background. We can see in the middle column here, we've got, what's over here? You can see in the middle column here that we've got the RBC, the antigens that they have. So if you have type AB blood, okay, you're going to have A and B flags or antigens. We see that here on this blood cell. No antibodies, because if you had anti-A, you'd latch onto the A flags. If you had anti-B, you'd latch onto the B flags. All right, so no antibodies, which means you can receive blood from anybody. Obviously, you can always receive from yourself, and you can always receive from O because it's a universal donor, but you can also receive from A and B because you got no antibodies to kill anything. Type B blood group, you got B flags, So you have anti-A, which means you can get from yourself, or you can receive from O, because O is the universal donor again. AB blood, just want to show up here, that's a universal recipient. Okay, you can only give to other ABs, because everybody else has got either an anti-A or an anti-B antigen in them, but you can receive from everybody. So it's kind of good blood if you're a selfish person. Type A, you've got anti-B, and you can receive from A or O. And type O blood is the universal donor because you got no ID flag, so it doesn't matter what antigens or antibodies the other person has. They're not going to kill your blood. They don't even know it's there. Bad thing is you can only receive from other O's. So you better be a pretty selfless person if you've got O-type blood, and hopefully you give a lot. Okay. The other thing is that whole plus and negative. I'm A positive or B negative or AB positive. That's called the RH blood group. It's called RH because it was first discovered back in rhesus monkeys, spelled with an RH. Here's a picture of one. They were found in rhesus monkeys, and you're either positive for that flag or negative, meaning you don't have that flag. It's a simple dominant recessive trait. Having it is dominant, not having it is recessive. Okay. The presence of the RH agglutinogens on the RBCs is indicated as a positive. Anti-RH antibodies are not spontaneously formed in an RH negative individual. So if you're like, say, A negative or O negative, you don't have anti-RH right away. It just doesn't happen. Okay. However, if you're a negative person and you receive positive blood at some point, or you're exposed to positive blood at some point, you will start making those RH antibodies. It's kind of like you may not have antibodies for COVID until after you're exposed to COVID, right? And then your body's going to start making some, so the next time you're exposed, you'll be able to fight it off. It's the same way that our immune system, we use vaccines to trigger our immune system to make the antibodies to kill it off before we get sick. So a second exposure to RH blood will result in that hemolytic reaction. So universal donor is O. The most universal donor is O neg, because you don't have any RH flags on there. In a pinch, could a doctor maybe give you O positive if that's all they had and they didn't know what your blood type was? Yeah, you'd be taking a gamble that the person hadn't been exposed to positive blood in the past, but it could happen. Okay. Now, this leads to an interesting thing called hemolytic disease of the newborn. This happens when a RH negative mother has a baby with a RH positive father, or RH positive baby specifically, which can only happen if the dad's positive, because RH is a dominant trait. So usually what happens, the mother, first time she gets pregnant, no problem, she has an RH positive baby, because the red blood cells from the baby don't cross into the mother. So even if the baby is RH positive and the mother is RH negative, the mom, remember, doesn't generally produce antibodies until she's been exposed. And she's not technically exposed to the baby's blood. The membrane, the placenta, where the blood from the baby and the mother come in close contact, but the blood actually never crosses that membrane. Okay, antibodies can cross it, nutrients can cross it, fluids can cross it, waste products can cross it, but the blood cells don't, which means the mother is never exposed to the baby's red blood cells. So she doesn't try to make antibodies to the baby's blood, and so she gives birth. Now, I don't know how many of you guys have ever witnessed birth, but there's usually a bit of blood involved. Blood from the baby and blood from the mother gets mixed during the birthing process. So after that first exposure, now the mother is going to start making RH antibodies. Not a problem if she doesn't have an RH positive kid again, but if she does have a kid who's RH positive again, her antibodies, which she's now producing for RH, are going to be able to cross the placental membrane, and they are going to attack the baby's blood cells. So that's what we call hemolytic disease of the newborn. Okay? And we can treat it with various drugs and things like that if the doctors know that you are at risk for it. So if you are an RH negative woman who plans on having kids someday, something you should be aware of, particularly if you wind up having a mate with positive blood. If your mate's got negative blood, nothing to worry about, unless you get a bad blood transfusion at some point that exposes you to positive blood. But it's something you should be aware of because it can cause miscarriages and stillbirth of the baby. This is one of fairly common reason why women in the past, they'd have a first child without too much trouble, and sometimes a second one, but they'd wind up with a lot of miscarriages, okay, after that first child. A likely culprit, we believe, for a lot of that was this hemolytic disease of the newborn. They didn't know about it, and they didn't have any way to test for it. They didn't have any way to treat it. So the first baby was usually fine. After that, it became harder to sustain a pregnancy if a negative woman was mating with a positive man. So if the baby came out positive, you'd get this problem. Okay. So blood typing, how do we do that? We're going to do this in lab. Okay. When a serum containing anti-A or anti-B, agglutinant, is added to blood, agglutination will occur, and you get clumping. So basically, we're going to take a sample of your blood, and we're going to put anti-A antibodies on it. If anti-A antibodies clump it up, okay, break it apart, make it look all nasty, you've got A blood, because anti-A kills A. If we put anti-B on it, anti-B kills B. So if anti-B goes on it and it clumps up, you've got B blood. Okay. If we put anti-RH on it, it clumps up. That means you got RHs. You're positive for RH. So if you clump up when we put the anti-A, anti-B, or anti-RH, you have those antigens. You have A if anti-A does it, B if anti-B does it, RH or positive if RH does it. If it stays looking the same, you don't have it. Okay. So here we can see this one here is smooth. The upper right corner, upper left corner, we have agglutination occurring. And down here we've got a little chart to kind of just bring it all out for you. Ideally, you'd be able to reproduce this chart on your own now that you know what's going on. We've got the blood type, the antigens that it has, and the serum that will react with it. Okay. And you can refer back to this then when we are doing our lab. And that does it for our notes on the blood. Once we're done with this, guys, we'll get started on the actual cardiovascular structures and functions, the heart, the arteries, the veins, what are the different parts of them and what do they do, and that type of stuff. So we will catch you later. Bye.